Welcome all, happy to see you again. Let's continue on with the topic of polyps. Today we are going to discuss about the neoplastic polyps. Now recall what's the last lecture is about? Yes, it's the non-neoplastic polyps. Do you remember the categories, that is classification of non-neoplastic polyps? Yes, these are the hematomatous polyps, the inflammatory polyps and the hyperplastic polyps. Today we are going to discuss briefly about the neoplastic polyps and let's move into the video. Now let's see about the introductory part. These neoplastic polyps are adenomas. What are these adenomas? These are harmless benign growths. But it's not that these are obviously harmless. Sometimes it may transform into a malignant tissue like the colonic adenomas and some pituitary adenomas also. When there is no medical intervention or for example surgical intervention is not done, these can transform into a neoplastic lesions in the GIT can produce a polyp. These polyps are, remember, these polyps are precursors to colorectal adenocarcinomas, and these are also precursors to other carcinomas like the neuroendocrine tumors, for example like MEN1 MEN2 syndrome, and stromal tumors, and also like other metastatic cancers also and lymphomas also. These can range from small pedunculated to large sessile lesions. These neoplastic lesions were less common in Asia, that is, they were less common in Asia, but now their incidence have been raised due to the introduction of the Western lifestyle like the eating of junk food and fast foods, etc. In Western people, that is in the Western world, 30% of the adults who are living with these neoplasms are by the age of 60, and whoever is having the family history of colorectal adenocarcinoma should be screened. They need to be screened. And surveillance is recommended between the age group of 45 to 50, which are the high risk age group, and surveillance is done by the instrument known as the colonoscopy. Prevalence of colorectal adenomas will correlate with that of the colorectal adenocarcinomas, and majority of adenoma will not develop into an adenocarcinoma. That is, if an adenoma is present, it will not definitely transform into adenocarcinoma. But if an adenocarcinoma is arised, it would have been from the adenomas only, and it is very difficult to identify which adenoma will transform into adenocarcinoma and which will not. So these are clinically silent, and the patient presentation will be at the advanced stage only, where it will develop into complication and it will really lose the patient. And large polyps will produce occult bleeding, which will progress into anemia. Now coming to the morphology, these adenomas are characterized by the presence of epithelial dysplasia. Their hallmarks include the nuclear hyperchromasia, elongation, stratification. Remember, we can remember this by SEN. Lakshya Sen. Do you know about Lakshya Sen? He's a famous badminton player. Lakshya Sen, SEN. Then these adenomas size range from 0.3 to 10 centimeter in diameter. They can be pedunculated or sessile. These pedunculated and sessile surface, both of these surface texture will be resembling that of the velvet or a raspberry. This is the picture of a polyp with the surface texture of velvet or raspberry. On examining in the microscope, these polyp can show prominent nucleoli and eosinophilic cytoplasm, and there will be reduction in the number of global cells. In case of pedunculated adenomas, the stalk is usually covered by a non-neoplastic epithelium. This is the image of a pedunculated adenoma. This is the stalk and this is the polyp head. Now coming to the morphological classification, there are three types. Morphologically, they can be classified as three types. These are tubular, villous, and the combining these two, tubulovillous. Tubular, these are small polyps, and these are pedunculated and rounded tubular glands. This image shows the image of a tubular polyp, where you can see tubular, I mean round structures. These are tubular glands. And villus, these are large. Tubular is small, it is large. Villus is large. These are pedunculated, these are sessile. These are rounded tubular glands, and these are slender villi. Villi are nothing but finger-like projections you can see here. These are villi. And tubulovillus shows the mixed morphology of both tubular and villus polyps. Now let's discuss about the sessile serrated adenomas, which overlap histologically with the hyperplastic polyp. I have told you in the part 1 video itself that the hyperplastic polyps resembles the malignant sessile serrated adenomas, and the most common region of occurrence of the sessile serrated adenomas are the right colon. They lack the cytological feature of dysplasia. These sessile serrated adenomas and hyperplastic polyp, they resemble each other. How will you differentiate between them? It is the presence of serrations in the full length of the glands in sessile serrated adenomas. This is the image of a sessile serrated adenoma. You can see serrations throughout the gland. From top to bottom, you can see serrations. These differentiate them from the hyperplastic polyps. Let's see about the intramucosal carcinoma, which occurs when the epithelial cells which undergone dysplasia, that is dysplastic epithelial cells, reaches the basement membrane and reaches the lamina propria, that is invasion of lamina propria, causes intramucosal carcinoma. They may extend the muscularis mucosa also. Here, the point to note is that there will be little or no metastatic potential because the colonic mucosa lacks a functional lymphatic channel. That is, functional lymphatic channel is absent in the colonic mucosa, which causes less or no metastatic potential. The invasion beyond the muscularis mucosa causes definite risk of spread of these intramucosal carcinomas. Now coming to the treatment. If there is no metastasis, then simply do colectomy and discharge the patient, that is removal of entire colon. In case of invasive or metastatic cancers, there are certain factors which determine the treatment. These could be histological grade, which could be high or low grade dysplasia, and the route of spread, which could be vascular, that is through blood or lymphatics, and the size of cancer, which could be less than 1 centimeter. It is the rate of spread is very less. In case of more than 4 centimeter, the rate of spread is high. These are certain factors which determines the treatment. With this, we have completed the entire topic of polyps. If you found this video to be useful, then subscribe our channel Medical Dafossa. Thank you.